Hello and welcome to this special ACR review podcast brought to you by the Lupus Forum. My name is Ed Vitale. I work at the University of Leeds in the UK and I'm the chair of the steering committee on the Lupus Forum. And today I'm very glad to be joined by my colleague, Professor Cynthia Aranow, who's a professor of medicine and co-director of the Clinical Autoimmunity Centre of Excellence at the Feinstein Institute of Medical Research in New York. Welcome, Cindy.
Thank you.
Did
And
you enjoy ACR?
I really did. And I'm really excited. There was so much lupus material that was presented
Yeah.
and looking forward to talking to you about it.
And a wide range of subjects as well. So we've tried to sort of represent that spectrum. Um, there's lots more lupus content than what we're talking about here. So if you haven't already seen it, there's this highlights brochure on the website where we've got more than 50 abstracts across the conference that we picked out covering a wide range of different subjects. And as always, if you want a similar kind of content to this, and to look at the key abstracts for rheumatoid, psoriatic arthritis, and axial spondyloarthropathies, then you can look at the highlights brochures and preview podcasts for those disease areas over on the Immune-Mediated Inflammatory Disease Forum. So let's get right into it with the first abstract. This is one of yours, isn't it?
Yes. So lupus made it to the primary plenary sessions. And the first abstract presented in the first plenary session is a really important study. So it's become increasingly apparent that we really don't know how to assess if a lupus patient with nephritis has really had a clinical response to our therapy or not. And we use proteinuria, which is okay, but it's become clear that if we were to rebiopsy lupus nephritis patients who seem to have responded to our therapy because they've had a significant drop in their urine protein, that they still have active kidney disease. And if we rebiopsy those who seem to have ongoing disease, that some of them actually have no activity in their biopsies. So we can't perform repeat biopsies on everyone. It would be wonderful to have a liquid biopsy if the urine could accurately reflect what's going on in the kidney. So what was done in this abstract by these investigators was using AI. They developed a panel of 13 proteins that they could measure in the urine and show that for patients with proliferative nephritis, class 3 or 4, that the urine panel corresponded to a repeat renal biopsy that had activity indices below 2. And it was much better than looking at the other markers that we typically use, such as C3, C4, DNA, or proteinuria. So they validated the model, and the top 3 components, in case any of you are interested, are the interferon gamma receptor, CD163, and something called CEA-CAM1. So they were also able to show that if they look at the trajectories of the panel in patients who've had a response after a year of treatment, and that those with complete responses had a different and higher trajectory than those that didn't. And it's worth noting that this panel is only good for proliferative disease. It doesn't work for membranous class 5. So this is clearly important and exciting, and it seems to be able to give us a non-invasive way of accurately assessing what's happening in the kidneys of patients receiving treatment for proliferative nephritis.
I agree. It's a great abstract, and I've found it frustrating for a long time that there is no way to know what's going on without really doing a biopsy. And so this is very welcome.
Absolutely.
Okay, so then one that I took a look at was a phase 1 study of a drug called zetomipzomib. So we've talked about this on some of the abstracts about this drug on Lupus Forum before. It's kind of interesting. It inhibits something called the immunoproteasome, which is involved in some cellular pathways involved in the production of cytokines, activation of immune cells. So interesting mechanism of action. There was a study done in lupus nephritis patients in the past, a phase 1, and that this is a reanalysis of that study. What they basically did here was in phase 1, you're often looking for quite small efficacy signals. So what they did was they pulled out patients who had highly active disease with many organs, and there were 10 of them, and 6 of the 10 got an SRI4. Um, However, um, separate from the work presented in this abstract, this study has actually been stopped. So if you haven't worked on clinical trials before, what usually happens is that during a clinical trial, there's a data monitoring committee formed who have the ability to look at safety data um, in the two subgroups. You don't usually know which one's the drug and which one's not. So they're just called something like green and blue. But you look at your two groups and you're checking for any safety differences between the two groups. And if you do see safety signals, then you can potentially actually stop the drug early. And that's what happened here, because in the phase 2 study, separate from this, there were 4 deaths in the zetomipzomib group. And as a result, that trial's been stopped. So that's a shame because it was an interesting mechanism of action, but it's also important that studies are monitored in that way.
Yeah, I think it's really disappointing. I mean,
Mm.
we're looking for safe and efficacious treatments, and if it's not safe, we just can't go forward.
Yeah,
So it'll be interesting to see what this company wants to do with this molecule going forward.
and exactly what were the details of what happened there?
Exactly.
Yeah. Okay.
So this next abstract is about a molecule that's actually quite safe. And I thought it was really interesting, given the interesting interest that we're all seeing in the sodium glucose transport 2 inhibitors, the SGLT2, in patients with lupus nephritis. So both the EULAR lupus guidelines as well as the ACR guidelines, which we're going to be talking about in a little bit for lupus nephritis, recommend considering use of these non-immunosuppressive agents as adjuvant therapy. So what this group did was to interrogate the Mass General Brigham database between March of 2023 and February of 2024, looking to see who and how many patients with lupus nephritis without type 1 diabetes, in whom it would be indicated, or end-stage renal disease, had received an SGLT2 inhibitor. And for a comparator group, they looked at patients who had not been given SGLT2 inhibitors, whoops, that's a mouthful, but who had initiated treatment with ACE inhibitors or ARBs. And what they found was that 6% of this population had initiated an SGLT2 inhibitor compared to 50% initiating ACE or ARBs. So not surprisingly, the SGLT2 inhibitor users had a higher mean weight loss over this time, which is what one would have expected. And that when they looked at the type of patients, 20% of them had type 2 diabetes. They looked at adverse events, looking at safety in the 2 groups, the SGLT2 inhibitors and those that had been given ARBs, and looked at GU infections, acute renal injury, fracture use, and did not see any significant differences. So I think that these results are truly interesting. I think we're learning more about these meds, and I expect that we're going to see greater use of them in our patients with lupus nephritis, but we clearly need more studies on their use and their effects on long-term kidney outcomes.
Yeah, it's very interesting these drugs because they've been used already for a variety of different renal diseases. They've
Mhm.
started using them in lupus nephritis without actually lupus specific studies, apart from this one. I did the Lupus Forum webinar on lupus nephritis with Brad Rovin, Liz Lightstone, and Maria Dalera, and said, who's already prescribing these in their clinic? And everyone put their hand up. So widespread use based on data mostly from other renal diseases up till now. So it's important to see this really.
Agreed.
Okay, so next one was an analysis of the Paisley study of deucravacitinib. Again, this is a drug we've talked about a few times. So deucravacitinib is a TYK2 inhibitor, which is part of the sort of JAK family, but it's probably the target that makes most sense for lupus because it's quite specific for type 1 interferon and IL-12/23. But because of that specificity for type 1 interferon, it may be a good one for lupus. It's already licensed for psoriasis, of course. So this Paisley study is the phase 2. It's already been presented and published, showing good efficacy in non-renal lupus, especially in skin disease. I was struck by the effect sizes there. There were a few different doses in the study, but here we're just looking at the dose of 3 milligrams twice daily. And what they're basically doing is looking at patient subgroups. This has now become a standard procedure, really, in lupus studies that once we see a positive effect, we then have to look at some of the most important groups of patients. So these are things like, well, as here, in fact, race or ancestry, glucocorticoid use, SLEDAI score, disease duration. Because some drugs do seem to favor certain subgroups. Here, the full details are on the slide, but although some other groups were quite small, it wasn't really I couldn't really see any convincing differences in efficacy from one subgroup to another. So the message is kind of it seems to have a similar effect across all of the subgroups that were studied. And it's great that the drug works across all patient groups, although, of course, everyone is still left with the question that it would be really nice if we knew which drug to give each patient. And we're probably not going to get that from such simple things as the SLEDAI score, I guess.
Yeah, we're still a bit away from precision medicine, knowing which drug to give to which patient. But it's really exciting, I think, that we're beginning to have our toolbox is expanding. And it looks like there may be several new agents that may be joining the tools that we already have. So I think that
Yeah,
this is really
that's
encouraging.
that's what I'm always saying is that when we get lots of licensed drugs, the questions start to get more complicated because it's not just shall I prescribe a drug, but you have to think about which one and which one for each person. But that's a good problem to have.
Absolutely. What I wanted to talk about next is actually not a abstract, but there was a session, a widely attended session on the ACR guidelines, which were just developed and were presented at the meeting by Lisa Samaritano. And then there were two other presentations following this and ways to actually implement it. So what you see here on this slide are sort of the baseline guidelines. There will be a publication that should be coming out within the next couple of months that you can read in detail. So and this was a monumentous task, but what these upcoming guidelines say, and this is not surprising, that one should biopsy a patient with suspected lupus nephritis versus non-biopsy, that hydroxychloroquine and ACE inhibitors or ARBs should be used in everyone except if there's a contraindication, and that steroids should be used. However, their use of steroids may be slightly different than what we're all doing at home, because what they are recommending is that all patients receive pulse steroids, 3 doses of corticosteroids. They didn't actually give us the dose to use. We know that there's a wide range. But then that the starting dose of glucocorticosteroids should be 40 milligrams. And I know that many of us, including myself, have used higher doses to start with, starting at 50 or 60. But they're recommending give the pulses and then gives 40, and then to have a rapid taper and to get down to 5 milligrams or less over the subsequent 6 months. So what they now have recommended, and you can see this, is something that I think we were only using in our sickest patients. And they are recommending that we use what they call triple therapy. So what this means is that corticosteroids mycophenolate, and then, and this is for class 3 or 4, to give belimumab or a calcineurin inhibitor. For class 5, proliferative disease, it's to give the triple therapy, again, triple therapy, um, with steroids, MMF, but here to use a calcineurin inhibitor. They do suggest, some alternatives. So, particularly in a patient who has extrarenal disease, one may want to think about belimumab versus a calcineurin inhibitor. There are also guidelines on what to do in terms of if there's a lack of response, and it basically includes, using perhaps the other agent. And although it's not their first line, is to think about use of IV cyclophosphamide, but to use the low dose, the Lupus cyclophosphamide. So, I mean, I think that this is really a major step forward. And I look forward to reading the publication when it comes out, because this is going to change how we treat our lupus nephritis patients. And I think it should result in better outcomes.
I was pleased to see this one too, actually, because in the EULAR guideline, which is an SLE guideline, it's not lupus nephritis specifically, but in that one, the different options are presented as all equal first line. So, like dual therapy with just mycophenolate and steroids is presented equal to triple therapy with mycophenolate, steroids, and belimumab, or mycophenolate, steroids, and voclosporin, etc. And I personally felt it shouldn't be that way, because we've got multiple RCTs showing that the combinations are better than the single agent, the dual therapy. They were licensed because they were better. And therefore those should be the preference. So I was quite glad to see this. I was also glad to see it because I'm busy in the moment writing the British guideline, and we came to the pretty much the same conclusion as on this slide. So that's quite reassuring.
So what I can tell you is that, in true transparency, I was involved in the development of these guidelines, and it was a monumental task. I mean, we read hundreds and went through hundreds of papers. So, but I think that the result is really interesting, and it's data-based.
Yeah, and it's really difficult to go from such a large amount of data in a complex process to something that looks very simple and elegant like this. So well done. Okay, so the next one actually is a perfect segue from that, because exactly as we were saying, you have multiple potential options to treat lupus nephritis that all have evidence of efficacy, but sometimes it's hard to choose between them. And that's what's been attempted in this study. So this is a randomized controlled trial that was conducted in India, where they took 3 different options for lupus nephritis and compared them head to head. So one is IV cyclophosphamide, one is mycophenolate, and the other is tacrolimus. All of these combined with glucocorticoids and hydroxychloroquine. Just a comparison of 3 different immunosuppressants. And essentially, as the figure shows, there were not really major differences seen between them. On one hand, the cyclophosphamide renal response at 24 weeks shown there looks a little bit lower than the other 2, but that group also got a faster reduction in proteinuria, and it's a non-significant difference. So I think essentially there are no differences revealed between them in this study. But it's really nice to see a head-to-head trial being attempted, because we really need them. But there are a few caveats here. One is there are only just over 20 patients in each arm. So to show the difference between active options, that isn't really enough. The other thing is that this is only 24 weeks follow-up, which is very short for a nephritis study, because even a year is probably not an ideal duration. It probably needs to be more like 18 months plus in lupus nephritis studies. I'll be looking out to see whether they publish any other longer-term follow-up in future. There was another thing they presented here, was that they looked at CXCL10 as a potential biomarker, showing that it comes down post-treatment. So again, some of these smaller RCTs can be very useful in terms of biomarker add-ons that occur in them. But essentially, I suppose this one at the moment, the three options tested all seem reasonable in terms of evidence, I think.
Yeah, I really like this one because we see so few head-to-head trials,
Yeah.
comparing what the different options are. And even though it's a small trial and it's a, short duration, I think it gives us really interesting data.
Yeah. And it leads the way of what we need to do.
hmm The next abstract um, deals with ABBV 599. And this is actually follow-up on the long-term extension study of the SLEEK, the SLE EK study, which was a trial of upadacitinib, ABBV 599, which is a combo drug consisting of upadacitinib and elsubrutinib, which is a selective Bruton's tyrosine uh, kinase inhibitor, to standard of care. So in the phase 2 study, active patients with SLE, this is general SLE, not renal nephritis, were randomized to receive either at ABBV 59 in a low or high dose, the Bruton tyrosine kinase inhibitor, upadacitinib 30 milligrams, or placebo. And in the interim analysis that was planned in that study, the low dose ABBV 599 and the elsubrutinib were discontinued due to lack of efficacy. And what they then showed is that at 48 weeks, that the patients on the high dose ABBV and the upadacitinib were statistically better in achieving disease outcome response than those receiving just standard of care. So here we have long-term extensions in which the two drug arms continued and the placebo arm was randomized to the high dose of the ABBV 599, the combo through week 104. And what they nicely show is that the proportion of responders, this is using SRI-4, continued to increase through week 104, and that the BICLA response, the achievement of LL-DAS, and flare rates were either maintained or particularly in the group that had received placebo and had been transitioned to active drug, had improved. They also reported that almost all patients, and this I thought was really important, were nearly steroid-free by week 104. Safety-wise, again, really important. There was no thromboembolism, no MACEs, major adverse cardiovascular events, and that the treatment emergent adverse events were similar among the two groups. And just, really briefly, and they looked at BILAG responses between the groups. And again, the results were really encouraging in that, there were improvements in the BILAGs in the domains that we would think would have should respond. And those are the most common domains that we see in lupus, the musculoskeletal and the skin.
Great. So actually, contrary to what I said earlier about TIC2, upadacitinib is actually looking quite promising, isn't it? So there's another agent in the JAK class
Mhm.
that's looking quite promising for SLE, but the BTK inhibition part, whilst it seems very appealing that you could block the B cells with the BTK inhibitor and some of the innate immunity with a JAK inhibitor, the BTK inhibitor part doesn't seem to contribute to this. One of many trials that have shown that BTK inhibitors aren't as useful as you might think they should be for lupus.
Or that we might have hoped. It really seems that that class of drugs, has, as we like to say, has hit the graveyard. But
Yeah.
there are clearly things like the JAK inhibitors that
But
really may be very encouraging.
yeah,
So,
that's right. And perhaps the reasons why the BTK inhibitors didn't work is quite interesting, actually, because what it might suggest is that B cell receptor signaling isn't as important as you think in established SLE. So this is an early phase development here, but it's an interesting target. So this VENT3 is an inhibitor of CGAS. So I think we're all familiar now that type 1 interferon signaling is really important in SLE. But what stimulates type 1 interferon signaling? So there are nucleic acid sensors. There are several different systems. There's TLR7, TLR9, CGAS and STING as presented here, MDA5, all these pattern recognition molecules that detect self-nucleic acids and lead to production of type 1 interferon. And we've thought for a long time that CGAS STING might be one of the most important of those, particularly in skin disease. So there's been interest in developing drugs that target that for some time. As I understand it, the process of developing a molecule that blocks CGAS STING is actually quite complex, but appears to have been successfully done here with this molecule called Vent3. So this is all preclinical work. It's actually being done in an animal model, which is a TREX1 knockout. So again, if you're not familiar with them, TREX1 knockout is an interferon-driven lupus model, which is why it's of interest here. And what they're showing here is that they get the expected effects on inflammation and lupus response in this animal model, including response to the provocation, which usually induces dermal inflammation. And they also included in the abstract a bit of human data just showing strong activation of C-gasting in lupus patients' skin. So no clinical data yet, but this is going to be an interesting mechanism of action in future, I think.
Yeah, I look forward to seeing the results of actually using this molecule in clinical trials in patients with lupus, particularly as you mentioned, patients with cutaneous lupus. So there's still lots on the horizon to come. This is a abstract looking at anifrolumab effects on response to influenza vaccine in lupus. And I like this abstract because I always worry about the ability of our patients to respond adequately to vaccines. And this was particularly true, if you remember, during COVID. Um, and I worry about patients who are on any immunosuppression, but I'm particularly concerned about those that are receiving biologics. So what these investigators did was to look at vaccine responses in 19, a rather small number of patients receiving anifrolumab, and that's the antibody to the interferon receptor, and compared it to the vaccine response of 6 lupus controls who are only receiving standard of care. And they looked at the immune response to influenza using both an antibody measured with an ELISA as well as a hemagglutinin inhibition assay. The patients could be on up to 30 milligrams of prednisone, could be receiving hydroxychloroquine or AZA, mycophenolate, or methotrexate. So patients could be on background immunosuppression. And what they found was that the immune response to influenza, the vaccine, was comparable between the 2 groups of patients, those receiving anifrolumab on the biologic and those not receiving it. And safety-wise, that the anifrolumab vaccine was well tolerated, and there were no unexpected safety findings in either groups, but particularly not in the group receiving anifrolumab, the biologic. So I think that this is a study that's quite reassuring to us, both in terms of efficacy of the vaccine, which is so important in terms of how we care for our lupus patients, as well as safety. It didn't induce flares. It didn't induce any major changes. I was really pleased to see that this work was done.
Yeah, that's really important information, actually.
Yeah.
Okay, so then this is another post hoc piece of work on a previous trial. So this is done by Meenakshi Jolly, who's worked a lot on how to measure quality of life in lupus patients and in lupus trials. And this is analysis of the Aurora 1 trial, which is the pivotal trial of voclosporin versus placebo for lupus nephritis. So what they've looked at here is a few different tools. They've looked at the Lupus Impact Tracker, the Lupus PRO and the SF36. So Lupus Impact Tracker is a quite quick 10-item questionnaire that just gives you a unidimensional score of quality of life. Lupus PRO is multidimensional, and it has health-related quality of life domains that are things like pain, physical health, and also some non-health related quality of life domains that are slightly more complex constructs, I suppose, things like social support, desire, satisfaction with care. And the SF36 is there as well. So in so of course the Aurora 1 study was a positive study. So they're looking here, if you look at complete renal response, voclosporin 40%, placebo 22.5%. But this analysis wasn't done according to the treatment groups. It's done according to whether you got a complete renal response. So in other words, how did the quality of life changes differ between those on placebo and those on voclosporin? Of course, important here to remember that when I say placebo, I mean placebo plus standard of care. So all these patients had active lupus nephritis at the start, and the ones on the placebo arm were also starting glucocorticoids and mycophenolate. It's just they weren't having the voclosporin part. So everyone was getting new treatment for an active lupus manifestation. And that's probably why actually it's not surprising that improvements were seen in both those who achieved complete renal response and those who didn't achieve complete renal response. It wasn't that some patients had no change in quality of life at all. But the Lupus Impact Tracker improved more in those with complete renal response than those without. And as shown on the table, there are a few other of the items where some of those things differ between the responders and the non-responders. So it's encouraging that we see some health-related quality of life improvement. There was also an interesting comment made that, well, it was interesting to me because I don't work on patient-reported outcomes very much, but that the Lupus Impact Tracker and the health-related quality of life parts of the Lupus PRO are kind of proximal, meaning quite directly related to the patient's symptoms, things like pain, cognition, etc. Whereas the non-health related quality of life parts of the Lupus PRO are more distal, which is more complex things about somebody's life overall. And they comment that the first group are quite useful in clinical trials where we're trying to see if certain treatments are useful or not, whereas the latter are more relevant to actually people's lives in the real world. So yes, I think we're still struggling with how to get good PRO improvements, and this is a nice step towards that.
But I think that it's really important that, we're encompassing the PROs that, yes, we want to see objective changes in disease activity, but how a patient feels and how the drug or what's going on with their general lupus activity affects them is so, so important. And we just haven't been paying enough attention to it. But in terms of actually measuring the responses, we need measurements. We need tools to measure it. So that's really exciting, to see one that these PROs were being used and comparing different types of PROs in the context of a lupus clinical trial.
Yeah, once again, it's like when you start to see more, when you start to get more therapy, more effective therapies available, you start thinking about higher hurdle endpoints than just response.
Yeah. So the other quick comment is that the patients who had been given the Voclo had been given triple therapy.
Yeah.
Compared to the ones who got the placebo, and that was double therapy. So,
right.
this is one of the studies that led to the lupus nephritis guidelines. Bringing it back. Okay. So this next abstract is looking at predictors of fracture in lupus, and it comes from Michelle Petrie and her group at Hopkins. So what they did is that they looked at the risk of fracture in a large cohort. They followed 2,806 patients with lupus over the years, 92% female, and just over 50% are white. And they looked at fracture or vertebral collapse. And what they found was a total of 293 fractures over a period from 1988 to 2023. which was a rate of 0.13 per patient years. So not surprisingly, they found that the cast of usual characters, age, sex, race, tobacco, and a low BMD were associated with fracture, and that gender, bone density, and stroke were risks even after adjusting for age and race. Surprisingly, low vitamin D was not a risk for fracture. So they looked at prednisone use, and as might be expected, more prednisone was a risk. So they looked at cumulative risk exposure, maximum dose, um, and those did, the more you gave, the higher the risk. But interestingly, giving prednisone intravenously or intramuscularly was not associated with fracture. And another important take-home point was that when they looked at the dose of prednisone, and higher doses are indeed associated with a higher fracture risk, that lower doses, so doses between 5 and 10, were also actually associated with fracture, highlighting that if we're going to taper and are looking to bring steroids down, and lower is always better, but that we should really be targeting a dose that's no greater than 5 milligrams. So to me, this was, or less. So to me, this was something that I'm going to take home with me. I always try to get my patients below 5. Sometimes people don't want to try to go below, but I think that this is yet another reason why we should be trying to get prednisone less than or than 5, no greater than 5.
Yeah, I agree, and that's also my practice as well. When people are on 5, I always sort of say every milligram under that is kind of worth having if possible, even if we only reduce partially.
Yeah, but this is also a reason to say we don't want to just stay at 7.5, which if you think
Yeah.
about the LL-DAS components, 7.5 is okay. But this is a reason to try to think about going even lower because it's safer for our patients' bones.
Right, yes. A hotly debated a point that has been actually. So yeah, that's right. That is important. Okay, so now we've got a few abstracts that are all about CAR T therapies. So I'm just going to run through 4 of them in fairly short order, and then we can chat a bit about them afterwards. So the first one is a early report on some data on a therapy called CABA-201. So this is fully human autologous anti-CD19 CAR T therapy. There's data being generated in 2 conditions. One is immune-mediated necrotizing myopathy, and that's a study called Reset Myositis. And the other one is in SLE, so that's a study called Reset SLE. So this therapy is like some of the other CAR Ts we've discussed, it's essentially aiming to deplete B cells profoundly, but for a relatively short time. Um, the data here is quite early, but they do demonstrate that the CAR T cells administered to the patients expand appropriately. That's what you want. And then they kill B cells rapidly, and you get complete B cell depletion by day 15. And then there's a little bit of clinical data here as well. So in the myositis patient, the myositis subject has an improvement in clinical symptoms, CK, muscle strength, and the antibody levels, whilst off methotrexate and steroids. And the SLE subject also shows a big improvement in the SLEDAI as well. So there's a little bit of clinical data in there just from 2 people. It was tolerated okay. So I think, yeah, it's promising that we're seeing accumulating clinical data. Although, as before, these are kind of these penny numbers of patients that we're getting in these reports. I'm really dying to see something a bit bigger. Okay, then perhaps I'll just carry on. So then another one I saw that caught my eye. So this is actually even earlier, actually, this is preclinical data, but this is a CAR T that aims not at all B cells, but a particular subset of B cells. So this there's been reports on these type of B cells for a long time. So these B cells called 9G4 B cells. So they've got a particular type of heavy chain subtype with this heavy variable gene 434, which carries the 9G4 idiotype. And this group of B cells are innately autoreactive and produce autoantibodies in SLE and some other autoimmune diseases as well. And what's been done here, and it just shows, I think, really the broader promise of the technology of cellular therapies. What they've done here is generated a CAR T cell that doesn't target all B cells through CD19. It targets the specific B cell receptor so that it kills cells that are most associated with the autoimmune disease rather than all B cells. And like I say, this is preclinical data. What they've shown is they can do it. They can kill those cells preferentially in the expected way. And we're now waiting to see some clinical data for the same therapy. Okay, then the next one. So now, again, slightly more interesting than just low numbers of patients with clinical responses. This is now about the quality of response that one sees after CAR T therapy, because some people, like myself, keep saying lupus is a bit more complicated than just B cells. It's got massive innate components to it. And are we really sure that just targeting B cells on its own is really going to put everyone into remission in a disease that has such a strong but genetic innate component to it? So now what we see with some of the CAR T studies is people start to look a bit more broadly at what kind of immune reset you really see. And this is a study that was done with single-cell RNA sequencing data on some patients after who had received CAR T therapy. And what they've particularly focused in on here is on inflammatory profile of neutrophils. So they worked on PBMCs. You don't get normal neutrophils in PBMCs, but you do get these low-density granulocytes within the PBMC portion of cells, and those low-density granulocytes seem to be ones that are important to lupus pathology. We've known this for some time, so their numbers accumulate in patients with SLE, and those are the cells that do a lot of netosis, so generate a lot of antigens, etc. So what they've shown here is that the proportion or the fraction of low-density granulocytes is reduced post-CAR T therapy. The bars are the opposite way around to what you might expect, but the number of these cells is going down. And also, when you look at you can do a thing called pseudo bulk, where you take your single cell data and put all the same cell type together, so you get a larger amount of RNA to analyze. And when you look at that, which is the next slide, then what you see is some other changes in the actual transcriptomic profile of those cells. So there's a volcano plot there showing that some transcripts are going up post-treatment, and some are going down post-treatment, especially something a molecule TNF-RSF1A, which is one of the TNF superfamily receptors. And there's also a signature of lots of genes for the overall inflammatory profile of the neutrophils, which they called core signature, and that also reduces after treatment. So it does suggest that CAR T therapy is having an effect more broadly just on B cells. But I would comment that many effective therapies will have broader immune effects than just their own target. And I guess we want to know whether changes like this persist long term after the therapy is finished. Okay, so the last of these abstracts on cellular therapies is looking at allogeneic CD19 CAR NK cells. So there's a couple of differences here. So allogeneic meaning that these cells come from other people, not from the patient's own cells. So that does require tissue typing, but it can have some advantages. It means that you don't need the leukapheresis step, and also cells taken from healthy individuals may be healthier cells than leukocytes from lupus patients. The other thing is this is a CAR NK, not a CAR T, which again may have some differences and some advantages. Um, so what we're seeing here is some early clinical data. So there are a total of 20 patients. There's dose level 1, 1 patient, dose level 2, 1 patient, dose level 3, 5 patients, and dose level 4, 13 patients. Um, uh, Median disease duration, 10 years. What they're saying is they saw B cell depletion, B cells coming back 2 to 3 months after therapy, pretty quick B cell return. It was generally the treatment seemed to be quite safe. We just got grade 1 cytokine release syndrome in 2 patients, but no other adverse events or infections observed. And then clinical responses. So 4 out of 8 patients with clinical data had DORIS remission, and 75% of them had LLDAS. So open label, small data seems effective, although it's not completely wiping out disease activity in everybody there. So I think my overall feeling from all these abstracts is there's a lot of excitement about CAR T, but it's a bit early to call that. And I kind of keep thinking, if this was any other therapy and I showed you these sort of small case series and said, look how good it is, you'd be quite skeptical, wouldn't you?
Yeah. I mean, the CAR T story has just exploded,
Mm.
and it's really promising, and it seems to be inducing these incredible responses. But as you've mentioned, the numbers are small, but there have been, the advantages of, maybe using an allogeneic, so you don't have to leukapheresis a patient and you can
Yeah,
just take it off of the shelf and is really promising. And also, if you can just begin to try to target specific autoreactive B cells, and I'm not sure that the one that you showed us on the 4G4 is actually all autoreactive B cells. That could be, and it was debated during the presentation.
yeah,
But this is incredible technology, and I think that it really offers a major advantage in terms of our current treatments. And patients are already asking me about this stuff.
yeah, same.
It's hitting the headline. So every bit, information is powerful, and I think that there's been tremendous advances over the last year.
Yeah, I think I agree. Yeah, it's early, but I think the diversity of different technologies that are possible, and this is only scratching the surface, even what we've talked about here, is what makes it seem exciting to me.
Exactly. Exactly.
Okay, so on to something else.
Mhm. Okay, so this is still novel, although perhaps not as novel as the CD4, as the CAR T therapy. Um, and this was looking at dapirolizumab. It was a large phase 3 study, so it's made it to phase 3 in general lupus, which is really encouraging given the so many disappointments that we've had along the road in lupus therapeutics. And so it's refreshing to see a success in phase 3. So dapirolizumab, or DAPI for short, is a monoclonal antibody which binds CD40 ligand. It's a secondary signal for T and B cell interactions. And importantly, the FC portion of this antibody was removed because there was a previous trial some time ago that had an unacceptable rate of thrombotic events, and it was then deemed that these thromboses occurred because of the FC portion of the agent was binding to platelets. Okay, so this study was a 48-week double-blind placebo-controlled trial in which patients with active lupus were randomized 2 to 1 to receive either DAPI and that was at a dose of 24 mg per kg, or placebo, both with standard of care intravenously. It's given IV every 4 weeks. Response was measured using the BICLA, and what they found was that almost 50%, 49.5% of those receiving the active drug had a BICLA response compared to only 34.5% receiving the placebo. And this was statistically significant. They also looked at the SRI-4 and saw an even greater effect size, a 60.1 response compared to a 41.1. Again, highly significant. A key secondary endpoint was prevention of severe flares, and that this was 11.6 in those receiving DAPI, compared to almost double that percentage in those getting standard of care only, and that was 23.4. And again, this was, highly significant. So the trial included a mandatory steroid taper. And when they looked at those patients that started from above 7.5 milligrams, 72.4% receiving active drug could reduce their prednisone dose to less than 7.5, compared to only 52.9 of those receiving placebo. Again, this was significant. Safety-wise, there were more treatment-emergent adverse events in the treated versus the placebo, but the proportion of those with serious treatment-emergent adverse events was lower in the active arm than in the controls. So this was a very encouraging study of a molecule that we all thought should work, showing impressive efficacy results and very acceptable safety results. And it'll be interesting to see, where this goes from here.
Yeah, I was involved in this trial, so I'm certainly excited about it. But there was one interesting thing about the primaries and secondaries here, which was that the primary was BICLA at week 48, and that was met. Then you have some secondaries, and they're tested in order, secondary endpoints. So if you don't meet one of them, you're meant to stop doing statistical tests because of multiplicity. So the first of the secondaries was the BICLA at 24 weeks, and that one actually wasn't met. There was a numeric difference, but it wasn't statistically significant, which should then mean that the other ones don't get formally tested, although you still look at them and report their nominal p-values.
Mm.
All the other ones after that then were met, as you say, quite strongly. So we had to sort of look across all of the data and decide how worried are we about this first key secondary that wasn't actually statistically significant. And the conclusion we drew was that wasn't that wasn't that big a deal really, and mostly the efficacy was seen across almost all the endpoints tested. And actually the drug probably was working quite fast as well, because the steroid dose is separating by 8 weeks. So it's not a case that it just took ages to work. There's just a little bit sort of bumpiness in the data at different time points, I guess.
Yeah, I mean, I think what this highlights is, the difficulty of the and complexity of how you design a clinical trial,
Yeah.
right? And wanting to look at multiple secondary endpoints, but then statistically saying, okay, we're only going to do this and then we're going to stop. But, what I found really encouraging here is that looking at the totality of the data, this really looks quite promising.
Exactly. Lupus is complex. The clinical trial endpoints are complex. Most studies of drugs that have, turned out to be effective drugs have had a little bit of variation in how they meet the different endpoints, and you have to look at the totality of it, as you say.
Yeah.
Okay, so now there's a couple of abstracts kind of that are both about other post hoc analyses of existing drugs, and both looking at kind of using biologics a bit earlier. So I'll present those two together as well. So one is belimumab, and it's belimumab from data from the previous clinical trials, but particularly analyzing the patients who had early disease. So what they call EYD is early disease, and ESD is established disease. And what early here means less than 2 years, which isn't that early, but it's still fairly early. So what they've done is look at flares. And flares are a good thing to look at in early disease patients because often you're looking at preventing worsening rather than necessarily improving. And in this pooled population, there were less severe SFI flares, any SFI flare or BIALAG flare over 52 weeks with belimumab as compared with placebo. Not all of those differences were statistically significant, but they were statistically significant for patients who had a damage score of 0 at baseline or no immunosuppressant use at baseline. So all of that seems to suggest that there is a value in using biologics early when patients have a lot of capacity to worsen, essentially.
Yeah, I mean, I think that the concept of treating early is really appealing because we may, if you treat early, actually change the course of disease, right?
Yeah,
Whereas, if you treat later, everything has become entrenched and there's already damage.
yeah,
One of the things that I worried about with this, though, is that, as you begin to have to really dig down to smaller and smaller subsets, you wonder about the generalizability. But the concept of treating early, with a biologic, which
yeah.
is going to change the immune response, I thought is really appealing.
Correct, because this is a disease where most of the severity occurs in year one. So reserving your best therapies until you're a bit down the line may be the
Yeah.
wrong way around. Okay. And then this is the other one that's also about earlier use of biologics. So this is with anifrolumab, again, post hoc analysis of data from the trials. But here, this is looking not so much at duration of time, but patients who had no prior immunosuppressant use. So again, so essentially it's testing use of biologics as first-line immunosuppressants in lupus, and the endpoint being tested here is DORIS remission. What's been shown here? So there were a total of 257 patients in the TULIP 1 and 2 trials who were naive to immunosuppressants. And of this group, 21 of them, which is 16% of the immunosuppressant naive patients on anifrolumab, achieved DORIS remission, which is the highest hurdle endpoint, really. SLEDAI 0, prednisolone 5 or less, PGA less than 0.5, compared with 7 patients or 6% of the immunosuppressant naive patients on the placebo group. So again, seems promising for the earlier use of biologics.
And in fact, although 16% of patients receiving the stringent criteria of DARS remission may seem low, but in comparison to those who had not received the biologic, I mean, that it's a really huge difference
Yeah,
and really encouraging. And that's 16%, and you can't compare across different trials, but the 16% of patients receiving a DARS remission in a clinical trial is actually quite impressive.
yeah, yeah. So it's not unusual to see a 10% delta on SRI-4 in some trials.
Yeah,
And here we've got a 10% delta on remission.
yeah.
Okay,
Last but not least.
so this is now a piece of work on ianalumab. So this is now we're now in phase 2. So ianalumab is a new biologic that's B-cell targeted and has this interesting kind of combination mode of action because it's a monoclonal antibody against the BAFF receptor. So it will stop BAFF, but it also actually kills the B cells. So it might combine some of the benefits of BAFF inhibition, i.e. B cell survival and differentiation, and also B cell killing. So we've seen the phase 2 data before, but this is an extension of that with some longer term follow-up out to 68 weeks. So the end point here is a composite because it's SRI4 plus corticosteroid reduction, not just SRI4 on its own. And you can see on the figure there that the proportion of patients meeting that endpoint on ianalumab is higher than it is for placebo in both the double-blind phase. And then when you get to the open label phase, what happens is the placebo patients switched over, so they were having active drug as well. And you can see that they then catch up with the ianalumab and actually maintain those responses through the safety follow-up phase as well. So this isn't a huge phase 2 study, but it's more encouraging data about efficacy here. And then there's one other last abstract now, also about the same drug on ianalumab. So this is now analysis of how that works, what this does. So they've taken samples from the phase 2 study and they've been analyzed using flow cytometry, so looking at B cell numbers of B cell subsets and also whole blood RNA sequencing. So lots of data, obviously, that potentially can be looked at, but a few things that stand out that are presented shown on the slide here. So all B cell subsets are down significantly, including plasmablasts, which is a subset that I studied a lot in my previous work. That's quite a good marker of B cell turnover and traffic and correlates with disease activity and relapses and things. So that effect was seen quite nicely and strongly. And then when you look at the RNA sequencing, the volcano plots that are shown on there, there are a few other things revealed. B cell receptor signaling was reduced, as you might expect, but also Fc gamma receptors and neutrophil degranulation. So going back to the comment I made before about CAR T therapy, lots of therapies that are effective here targeting B cells with a monoclonal antibody also leads to these broader effects on some of the innate immune functions. There's also some proteomic data here as well, which isn't shown on the slide, but also shows B cell and neutrophil related proteins reduced. So all encouraging information about this molecule.
And I think it's so important that that these investigators looked at mechanistic studies because it really gives us the opportunity to not only see how the drug, the agent may be exerting its effects, but it also, begins to give us clues in terms of unraveling, the complexities of the immune response in lupus and the techniques that we now have to actually look and examine the effects of drugs, of agents on the immune system have just exploded. So, one, I applaud that they did this study, the clinical study, which is really encouraging, but they took the extra time and effort to begin to look at mechanism, and
Yeah.
that's really important.
Well, that's all we have time for, folks. I hope you've enjoyed this review podcast. Don't forget to visit the Lupus Forum. That's lupus-forum.com. And there you'll find a really big range of other great lupus content, which includes some detailed slide decks of the top research, monthly podcasts, and special webinars on key topics of interest. The slides you've seen here are all freely available to download as well, so you can use those in your own teaching and your journal clubs. So thank you. And as always, best of luck in your clinical practice.